Ladies and gentlemen, today we're speaking about how to shape tomorrow's healthcare ecosystems. In this day and age, there's not been more capital and more technology available to the sector of healthcare ever in the past, as it is today. My name is Mauricio Suazua. I'm the CEO of Carney, Middle East and Africa. It is a pleasure for me to be here, accompanied by such luminaries in the sector. So let me quickly introduce them to help us unpack this situation about capital availability, capital deployment, healthcare outcomes, pursuing opportunities that are there for the taking in MENA, incorporating technology into the healthcare continuum, and also dealing with talent, something that I'm sure our panelists will illustrate us about. First, Dr. Sunita Reddy. She leads Apollo Hospitals, one of the world's largest privately held healthcare providers, spanning hospitals, diagnostics, pharmacies, digital health, with deep experience, Dr. Sunita, in scaling quality care across diverse populations. Another topic we're going to talk about is accessibility and affordability today. We're also joined by Dr. Shamsheer Vayali. Welcome, Dr. Shamsheer. He is the founder of Burjeel, one of the GCC's most successful homegrown healthcare platforms, built from greenfield into a regional leader across tertiary and specialty care. And finally, but certainly not leastly, Mr. Razi Al-Merbati. He's the CEO in GFH Capital, and he's also the Chief Placement Officer. So he will help us with his lifetime of experience in banking in multiple subsectors, and will give us a view of the evolution of building healthcare platforms in MENA with a return of invested capital perspective. So before we start and into questions, I'd like to just kind of situate the appreciation, if I may. Number one, we are facing tremendous amount of opportunities in MENA. The opportunities are large. The sector is set to double in the next few years. Women's healthcare outcomes are not where they need to be. This is not only a MENA phenomenon, this is a global phenomenon. In my firm, Carney, we've been leaning into that topic about how does the world cater to women's health in a much more direct and improved way. Wellness is being expanded significantly, and I'd like to explore today how wellness connects to healthcare, from preventative to all the way to consumer goods and other aspects of wellness. Secondly, the second pillar, the first one was opportunities. The second is about money, and I'll connect it to tech. I think we are well aware that there's tens of billions of dollars flowing to AI applied to healthcare around the world. So the question is, how much are these investments already yielding results? And I'd love to hear the panelists' views. And if not yet, when? And are they going to start impacting outcomes? Finally, but a very important aspect is talent. And to talent, I will connect capability and know-how. Because as we are chasing an industry that is being accelerated with technology, perhaps the capabilities need to be changing as well. And I'd love us to explore those things. So this is just to situate the appreciation of how do we shape healthcare systems. So let's start with opportunities, if I may. And Razi, if I may start with you.
Please.
There's clearly unmet healthcare demand in our region, in Middle East and North Africa. But likely not all segments are created equal. There may be differences in opportunity. Where is the money going from the likes of yourselves, but also other investors? And which subsegments would you say are most resilient and more needing capital today?
So thank you for the question. First of all, may I just welcome everyone to the GFH Pavilion, and thank you for coming. And I liked how you outlined, and shaped up the points. And I think there are very important points here. But going back to your question, I think we all agree that there have been significant investments in healthcare over the past, let's say, 10 or so years. But rightfully, like you pointed out, not all segments nor geographies benefited from that capital deployment. So, and in my humble view, you take places like, let's say, the UAE or Saudi Arabia, where you have significant growth potential, and then you compare geographies within that countries. So let's take an example of Saudi Arabia. So Saudi Arabia, in Riyadh, population a few years back was around 7 million. With a bed availability at that point around the 2.2 per 1,000. Fast forward a few years, population grew to 9 million. You would assume bed availability might go back, but because of investments, significant investments in tertiary and primary care in Riyadh over the past few years, those numbers have actually slightly increased, reaching to around the 2.5 based on certain estimates. Okay. Now take that and compare it to what's happening in second-tier cities in Saudi Arabia. Think of Abha, Hassa, all of the smaller, considered smaller cities, and you'd see that bed availability is still languishing at the sub-2 levels, which is below national averages. Now, here is where people such as ourselves, and I'm sure different healthcare providers are also looking into, we have invested significantly in these cities, but through applying, the integrated service providing models or the hub and spoke, investing in a tertiary hospital serving as the hub, flanked by strategically located specialty clinics serving as the spokes to that hub. Okay. And we have applied that, and I think that is more cost efficient, reaching a bigger reach for us. Now, I just want to point on another thing which you mentioned.
Yes, go ahead.
Segments. I believe human capital in healthcare is quite significant, and irrespective of cycles, where you are, and I see my colleague Fatma here, so she's our specialist in education. Investing in healthcare education, irrespective of cycles, is also very important. In our region, healthcare operators still are struggling with availability of nursing, specialized physicians. So that is also a point that I'd like to point out too.
Could you expand a little bit on what on healthcare education are you looking?
So we need, I think, we need to invest more. We need to invest more to have more localized talent, irrespective of nationality, but localized. Today there are significant need for nurses and special physicians across everywhere. Now, again, I also believe that we can enhance our R&D, localized R&D. Regionally, we have focused on developing hospitals, developing clinics, but R&D, we're still depending on the West to give us, research on developments on new medications, so on and so forth. So I think that's an area that we need to localize also.
That's very interesting. Yeah. Thank you, Razi. Maybe continuing on that same vein, very interested to hear your views, Dr. Sunita and Dr. Shamsher, of opportunities. Where have you been deploying capital lately? And as you look forward into, say, the next 10 years, I suspect that you're deploying capital for the here and now and fulfilling demands that we know of today. But there may be another horizon of investment into the future. Needs are changing. Technology is changing the way you deliver care. Also, disease is evolving. I'd love you to comment on how do you see this dual lens of where you deploy capital and today, and where do you expect to be doing it for the future?
So clearly, what we do is really driven because my father was the founder of Apollo. He came back from the US about 50 years ago, and Apollo is now 40 years. So we were the first company to attract FDI into healthcare in India. And really at that what the primary need of the patient was for good quality healthcare. So if you look at in terms of infrastructure, and if you look at just the hospital-based system, if India has only one bed for every 100,000 people.
Wow.
The WHO requirement is 4. So there is a structural demand for good quality beds, and therefore the investment into hospitals, whether it's it started in the mega cities, because of the availability of very good doctors. The second part of what we do was to bring doctors back from the US and abroad. Because, like it was mentioned earlier, human capital is very important to complete what we do as healthcare players. So bringing back capital bringing back human capital was very important. And I think that once you've established the system and you have built the intellectual property, the sharing of intellectual property from overseas, from the West, whether it's in research or in new ideas, except for pharmaceuticals when it reaches a certain age, the sharing of intellectual property is crucial. And I think those are the areas where we should remove barriers, whether it's healthcare education, whether it's how we're doing things with AI, everything we're getting from the West at a cost. So I think we really need to look at that, because capital flows, I can see Davos is full of bankers. So the capital flows are there.
They're looking to place money.
But yes, capital is here. I think what we need to do is to show them that we have the intellectual capital and make sure that we're able to deliver on, for us, it's good clinical outcomes at scale. So currently we have 11,000 beds, growing to 16,000 beds in the next 5 years.
Wow.
But more importantly, after recognizing that we've done the beds, we said the consumer counts, and we want to move closer to the consumer. In that journey of moving closer to the consumer, we've developed 24/7, which is our digital app. And through 24/7, you download the app. You can get a doctor consult in 20 minutes. You can get some medicine from one of our 7,000 pharmacies within 20 minutes. You can get
20 minutes.
You can get a phlebotomist from 2,000 of our centers, our diagnostic centers, and that might take time, but we'll arrange it for you, and concierge into the hospital. So everything for us revolves around what the patient needs, and our journey has been to move closer to the patient.
Dr. Sunita, that's fascinating. I wanted to touch on telemedicine in a second. So you already started answering the question, but before we go to that, you said more sharing of IP as opposed to importing it.
Yeah.
Can you expand on that? What do you mean? It's about sharing among groups in the region?
Yeah, I think, medicine is changing, and it's changing very fast. From when we entered India, if you had a cardiac problem, cardiac surgery, now it's moved. Even a valve replacement is done with minimally invasive. Cardiac surgery is minimally invasive. So I think that sort of learning on moving up the ladder in terms of clinical learning is very crucial to being relevant. And I think that without it, we'd just be backward in terms of the clinical work that we do. Second, I believe cost is also important. India's success is because we're able to re-engineer the whole process at 1/10 of the cost. So if you compare us to the US, we're at 1/10. We're half of Singapore and 1/3 of Singapore and 1.5 of Thailand. So this is a huge value proposition.
Is that because of talent cost,
It's
or is
because
that
of
more?
bringing the talent together and re-engineering the cost process. So we're faster. We're able to, we use generic medicines now because so much India's pharmacy to the world. We're also able to, we generate volumes because we use our technology much faster.
It's time to start exporting it.
It's high asset utilization that happens. So it is at 1/10 of the cost, and I think that is a huge value proposition. So I think we would like to share this with the rest of the world. We would like to go to Africa. We would like to go to the Middle East. and say, this is what you can do, what we can do for you. So from having 80% of Indians go to the US for healthcare, now patients from 147 countries come to us, and we're able to serve people in Tier 2 and Tier 3, which is the telemedicine and the other part that we can talk
Fascinating.
about.
I think that serves as a starting point. Dr. Shamsher, maybe your reaction also on where you are, where you see the growth in the next few years.
I started the hospital in 2007. I'm a radiologist by training, but her father had a big influence on me because I did my radiology in Chennai.
Okay.
Yeah, so I met him once in a train.
Incredible.
And remember his memory. I was just went and said, "You are the inspiration." He asked me, "What do you do?" I said, "I'm doing my final year." And apparently I was in the same hospital after 3 or 4 years with one of my relatives. So I felt a shoulder on my back, and it was the founder.
Oh, wow.
And he says, "Did you finish your MD?" I'm sure the memory was amazing, but the way such visionary leaders existed was something food for thought. Again, that's a great.
I'm sure GFH knew about that, and that's why they
We did
brought
that
you together.
by design, yeah.
What we did, we started off with one hospital. So what we were doing is essentially bringing all the patients into it. So then the employers came and said, "You know what? You're taking our employees out. We lose the man hours." So that gave us the idea of starting a separate company, which is a pre-hospital care company. We do oil and gas. We do ADNOC exclusive. We have 200 clinics only with ADNOC.
Okay.
So the offshore, onshore. We have North Sea installations. We acquired units in UK, Norway. We have an animal lab. So what we said is, let's go create value-based products. Let's design the product based on the needs. Because who's paying is also very important, right? Because if an employer is paying, we need to make sure the productivity of those people that pays for us is at the maximum, not taking them.
Right.
So that is the pre-hospital care of it. We listed that company. We have IHC is one of our partners. Hospitals grew. We went into designing the hospitals. We went into industrial hospitals because the kind of diseases are completely different. Infectious diseases, polytrauma, occupational health.
I see.
So when they come, they get more precise attention. We know when a person come from a camp with infectious disease, then the whole camp might get infected. So we give them vaccines. So that really worked. Then we said, let's design something for day surgery.
For purpose.
Yeah, it's all for purpose. So our journey has been evolved around designing the products. We went into oncology. We have the largest onco network in the region. We went to Saudi, very interesting story. We decided to do more community-based practices. So we designed a physiotherapy center. And we said, let's do it in the gym. So again, we did almost 30 of them in 8 months. So what we are trying to do is, the hospitals are getting more and more expensive, and it's becoming very crowded. What people want is more personalized kind of an attention.
Crowded in the hospitals.
You go to any hospital, managed well. You see that there is patients who needs to be there, and at the same time who need not be in a hospital. They could be treated better in a community setting. So what we are trying to do is go beyond the walls. And for that, we wanted data. So we went with Oracle. We adopted the first EMR from Oracle, which is the next generation, where we had the access to one of the first out of US deployments, which is again helping physicians to spend more time with the patients. So we also look at AI not to replace, but to empower and to give them more face time with the patient. So again, more designed around patient at the center, employer at the center, multiple price points. Then we said, you know what, we need the pharma. So we acquired a pharma. We got it into US FDA. But the interesting fact is that now we bring in trials where we have the best diverse population in any geography in the world, where now trials are more and more inclusive, more diverse data sets they need.
Okay.
And last year alone, we did more than 50 trials. So again, looking at the whole concept of bedside to bedside is what we feel, designing the care before the cure. What we want is not just a transactional sort of a engagement with our patients.
And wait for the next disease to show up. But
Don't be reactive. Let's
Preventive.
let's go into preventive. We have the best genomic labs. So again, we're doing stem cell trials on OA, osteoarthritis, so that it can delay or again help patients to lead a normal lifestyle without even looking at how to get into a surgical suite when they are active. So again, a lot of we said, let's move all the OR assets into one company, because operating rooms are the most sophisticated part of a hospital. So we are not trying to build more beds. What we're trying to do is build more efficiency into the system, bring more automation.
Ad hoc services.
So again, that's how the whole story is. We're just defining. And we work with UAE government across sub-Saharan Africa. So that's also, we manage the ship in Arish, which is docked. So what we did was created a concept called as container hospitals. Container hospital. We designed the hospital inside the shipping containers. This is again
for emergency situations
everything,
or just
deployments. If you see some of the new concepts, you will not realize it's a container. So, but they're more durable, and there are a lot of containers, but we customize it.
You can take it anywhere.
So a lot of innovation is what we welcome, and definitely India is, for a scale, we have hospitals in India where we could never crack, because that model is completely different. But I think we are getting there. I think the bridge is what needs to happen. The capital flow from the GCC, the talent pool, the tech from US. So that combination is starting to show, because we did a recent listing where we invited GFH to be a part, but unfortunately they were late. So we did a successful listing in Saudi on education platform.
Yeah.
So we took we have a higher education platform where we carved it out and we took it to the Saudi Tadawul, one of the Al-Masarij, you know that. So again, special needs. So the blend of healthcare with building the capacity is the next way forward.
Well, you are clearly answering a slew of questions that I had for you. I wanted to ask, what are the success factors of growing such a unicorn in such a little amount of time? And I think you already started answering that. Just a quick follow-up. If you were to talk about other unicorns like what you built in the region, private equity investors are complaining that there's no investable assets sufficient to place in capital. And Razi, I will get your input as well. But what would you tell the Dr. Shamsher that is right now in 2007?
Don't go just behind the P&L. Go for the narrative. Go for the equity story. And take the bet on the founders. I hate the word unicorns, billionaires, but the problem is the healthcare is very different. What works in one of my hospitals won't work in the other hospital. It's very different from each other. So again, that's where the consistency part needs to come. And I think if you take India, 90% of the hospitals are PE backed. 99? It's so much full of PEs.
Okay.
But the problem is now the people have started asking questions, because PE wants the returns. PE wants double digit, high teens. Again, how do you keep balancing the scale, the price arbitrage, the quality, the consistency, ethics, the morals, all of those things? People need answers. So I think looking healthcare at scale is very important. What she has got the product in India, if we can bridge it, reverse engineer, and I think we'll soon see companies like us going back to US, bringing down, because US works
down costs.
Yeah, because US works on
and improving outcomes.
Right? If you ask Mayo or Johns Hopkins to come out and do a hospital, they cannot succeed. The plug and play doesn't work.
Cost basis that they cannot.
Not only the cost, again, the secret recipe, right? There's no, because they're not for profit, so there's no real incentive for them to bring down costs or efficiencies to that level. So again, more different thought process. I think here we have a need. Probably they have more of a luxury or a thing. But again, it's a good arbitrage.
So it's two takeaways from what you just said. P's are greedy, and tongue in cheek, of course.
Greedy. I don't think there's anything wrong in being greedy. Yeah. But aligning the incentives is important. And I think GFH, you've done it very successfully, Razi. Before we go to the tech aspect, I just want to wrap up this. What's your view on availability of other interesting deployment opportunities for your capital in healthcare?
So just with regards to the unicorns, I'm to be honest, we're very humbled to be sitting across two of the leading groups in healthcare. Now, we believe GFH is leading hopefully the next unicorn, or if we want to just avoid using those labels, but the next group that can be listed or earmarked to be listed within the next 12 months. So currently we operate across 5 hospitals between UAE and Saudi, operating more than 50 clinics, seeing over 1 million patients a year. And I think we have a unique proposition in our platform where we are targeting secondary cities across the region, and trying to inject more capital in those where you have, again, being private equity, looking at margins, but at the same time looking at health outcomes.
That's right.
That's a fine line that you have to always look into.
And I want to come back to the aspect of health outcomes. And I really commend you for entering tier 2 cities, because we frequently talk about top technological advancements, etc., but it needs to reach populations. I think you all have done in different ways investments to actually reach different populations. So if we turn this into technology and outcomes, Dr. Sunita, I want to start with you. We're in Davos. We need to talk about AI. So forgive me for doing so, but it's the talk of the town. And some say that 2006 is the turnaround point where hype becomes measurable outcomes. I'd love to hear your views of where are you deploying AI? Are you seeing returns? And do you agree with what I just said about the turning points?
No, we are deploying AI. And like Shamshi said, what we're doing is reducing the workload so doctors and nurses can concentrate on spending time with patients and looking at critical factors that influence better clinical outcomes. But more importantly, on a trial level, we worked with Microsoft to develop the cardiac risk score. So at Apollo, we're very focused on prevention.
Can you repeat with the cardiac what?
The cardiac risk score, because
Risk score.
40% of Indians are all predisposed towards a heart attack because we have narrower arteries. So using that cardiac risk score, we came up with the preventive protocol that actually reduced the incidence of heart attacks among those who were part of our preventive healthcare program. So this happened, I think, almost a decade ago. So we have been very connected with what's happening with AI and how it can be used. So currently, while we're working on some of these, whether it's a stroke protocol or a cardiac protocol or something to do with the liver, which are crucial, because in India, again, the population is different. It's a heterogeneous population. We need to have unique systems that understand our data. And I think the good thing about Apollo is that now we've created this separate company, which is a pharmacy company, and it has the digital data lake, where we have about 40 million records with us. So using that, I think agentic AI, we were able to develop the clinical intelligence engine. And the clinical intelligence engine works across geographies. So for doctors who are in Tier 2, Tier 3, they're able to use the clinical intelligence engine to support some of their diagnostic or their, whatever they feel is the right protocol to use for the patient. So the clinical intelligence agent, I believe, is a game changer, the engine that we have. And we developed it, we used McKinsey as part of that, but we did a lot of development in-house. Now we're working with Microsoft and to develop, what a hospital would require in terms of supporting nurses, doctors, and information about the patient. So in this, we are very, very careful in terms of, because the Data Protection and Privacy Act in India is very
strict.
Very strict. So we're very careful about how we use data, but we are working with Microsoft because without a doubt, there's a lot of work that AI will transform healthcare. It'll make it faster, quicker decision making. It'll probably replace some of the tedious and very, very hard work that happens.
When do you expect that those
The change has already started. See, so today it's a cost. it is a cost, and it will be a cost if you're going to pay Microsoft for Copilot. It will be a cost. But sometime in the future, it's like in the blood you have hemoglobin and you have plasma.
It'll be
It's
embedded.
there. It's like the internet. AI will be like the internet. And I think if the earlier you start the early adoption is a cost. But the dividends will come later.
Great. Shamsher, maybe your reactions to where are you seeing highest ROI, whether it's financial or in outcomes, and what are you most excited about in the next, say, 2-3 years?
So we just launched a 2.0 version of what we do right now. So we had a town hall of almost 8,500 people. So it was fun. It was in a arena. So it was so much of
really?
high intense. It was so emotional to see all of them under one group. It was like probably the largest town hall in the corporate history. So again,
How many people again?
8,500.
Wow.
So it was like a Coldplay with the bands and stuff. So again, what we want is more clarity to communicate to the people, right? Because for us, it's a very different workforce. It's not like India. It's where people all come for a job to make money. Some people are builders, some people are workers. So again, we balance them well. We put the layer around them to let them grow as well. So I think AI adoption will be one of the very interesting topics that would definitely be seen in the near future. We already started. We have planned for taking out our call centers. So every call will be taken by an agent. And again, the people feel more comfortable when they know that they can chat with the agents. Yeah. So probably again, those elements of the repetitive jobs being moved into AI framework. And plus we have clinical AI agents as well. So post the colonoscopy calls, we now, rather than a nurse calling, there's an agent calling and giving them the full breadth of what it is, the triaging. Again, we developed a protocol for sunstroke because we do emergency services during Hajj.
Okay.
Last year, we managed the metro stations across all the Haram.
Oh, wow.
And what we did was, normally what they used to do was mobilize and take them to the hospitals. What we did was treat and discharge on the site.
On site.
So it was all the backpacks. It was a very intense training protocol. We deployed around 450 paramedics for just 10 days of Hajj. So again,
And you empower them, the AI
they have a pad where they have the back-end call center to support them. There's a doctor who's looking at this population, who's looking into the leads, the whatever they do, single leads, and all those stuff are connected. So again, probably what we want is the ability to process the data and the communicating tools. So some of the field hospitals that we do have Starlinks, we have to train the local resources because we cannot export all the talent to these markets. So we have very remote places like Chad, where we manage 4 hospitals. We train local indigenous people to look after the healthcare because otherwise it's not a sustainable model.
Right.
The cost is a limiting factor. Everyone wants a cost plus model. So I think the honeymoon is over.
Right.
The reality is coming in. So it's time that the VCs or the Ps stand with the founders, the pharma, the aligning of incentives is, I think, very, very critical at this stage because we have the most unavoidable part is the physicians, right? That's a very scarce, and there are very few star physicians, very difficult to duplicate them. So all those things will turn out, and the healthcare needs are increasing. So capitation models are coming. When we are sent to African countries, we prefer to meet with the Minister of Economy or Finance rather than the health.
Than the healthcare.
Yeah, because what happens is we talk directly on population health, how we think we can reduce the cost.
About productivity and
Budgets, how much we can
outcomes.
save. So Ethiopia, our strategy will be different because they have strong logistics. To Cameroon, where we have to enter through. So we have a logistic partner. We formed a company with Abu Dhabi ports because they have the ships, they have the free zones, they have the trade corridors. So we said, let's connect logistics into health.
Yeah.
So again, we call it Doctor.
Yeah.
Companies call it Doctor. Again, very interesting stuff of scaling up healthcare in Africa at 1/4 of the cost. Because building hospital, we built something in Liberia. What was 2-year project took 3 years because of the rains and no roads. So again, we have such interesting projects every day. And sitting in Abu Dhabi, there's always something because the leaders are very fast. and
Yeah.
they take decisions and they want to see the outcomes tomorrow. So
That's the beauty of the governance in our region. Very rich. There's a lot of wealth of topics I want to explore. I know that we're only like 5 minutes away from the end of the panel. So very quickly, you talked about the agent calling people. You also talked about making sure that all your staff embraces the use of AI. Typically, the biggest problem we see is adoption because of human factors. Whether I tolerate that a machine is calling me about my health, or whether I really want to use a machine to help me diagnose. How are you dealing with adoption?
So I think AI agent is more culturally aligned, and it doesn't have any emotional spikes. It is so intelligent, so it even changes according to the accent. So if suddenly the patient is a Kaleji accent, it speaks that accent.
Okay.
And they are put to comfort because the agent is so advanced. And probably what we heard on the last call was that the call, which was supposed to be 5-10 minutes, went to 45 minutes. So the patient started asking about diet or what should I eat, what is carbs versus protein. So the doctor or the nurse don't have time because they are so busy with the day-to-day. So I think this is coming for sure. What we want to see is like what we have to be like a Facebook of healthcare. It's not just when you come to the hospital, but we know what time you go to the bathroom, or whether you have increased frequency. So all of those things, making sure that the person has a better productive life.
And how do you supervise for hallucinations on that interaction and any risks around that?
See, there's always a risk in any new technology that comes, and it has to be closely watched, the data sets, the repetitiveness. Hallucination is definitely a problem, right? And we don't want that fear to confuse our whole objective.
It shouldn't stop you, but maybe you have some protocols
We have
to
also
mitigate.
have failures, right? IBM Watson. It came up with so much hype, but we don't even talk about it. It's out of our memory.
Yeah, that's
So,
right.
Again, so this is now the next stage where people like Apollo will definitely lead this race because I don't think they can build enough number of hospitals across the country. So, yeah.
Great. Just to make sure that we cover all the topics, I want to move to talent and know-how. And Dr. Sunita, you talked about building the skills of your clinicians, and perhaps it goes beyond clinicians. Now it's you also have technologists or coders, etc. How do you build that? How do you deal with the massive amount of training that you need in your system in order to cope with also the changes that are happening so quickly?
So what we do, we have 2 undergrad medical colleges. And when we say medical colleges, they have, they train everyone required in healthcare, from physiotherapists, everyone across the spectrum, radiologists, all of them get trained. We have 2 huge campuses in Hyderabad and one in Andhra and Chittoor, where this training happens. We collaborate with universities like Leicester University in the UK to make sure that we're upgrading their skills constantly, whether it has to do with, how you're using AI or it's just that the skilling, upgrading has to happen. So you get the basic degree and we make sure, and for doctors, they study in our hospital, we send them abroad for training. We upgrade their skill sets. So this is part of what we do. We have about 19 colleges of nursing. So we have a continuous supply of doctors and nurses and paramedics that are required for the system. And I think this is an inherent strength in Apollo, because if we have to grow, we need the people to grow. We understand the strength of AI, so we work with it. But let's not forget that at the end of the day, the human touch also counts.
Absolutely.
The warmth that a nurse provides, a doctor provides, are also very important. So skilling is important. And I think, I never said this, but, we work with state governments so that we can really leverage the intellectual property we've done in terms of telemedicine. And this is where, we do 15,000 consults a day. We look after 200 hospital ICUs, which are not ours. We look after, so we are able to triage at the right time. And I don't know if I probably don't have time to this, but since so much of the conversation is about PE, I have to say that, they're different. What's happening across the world in the US and in different parts of the world is that people are looking at profit pools. is when they make investments. If you look at insurance, people will invest in an insurance company, and for them their profit pool is 6%. And now in US it's moved to doctor practices, because you spoke about the shortage of doctors. And there again you pull out the profit pools, which is 8 to 9 to 10%. I think this, talking about profit pools and getting investment into different profit pools, at some time we have to think of how do we do this better? How do we do it in a way that, is cost effective for the patient as well? And I think bringing the holistic, so we have a TPA also which works with the insurance companies. So bringing it all together and thinking of that, creating a company that is evergreen, because it has to be dynamic.
You need to continue
and we
to
have
modernize.
to continue to change. So I think staying relevant for the future is very important.
Very well. I am sorry, I have to end the panel. I'm getting frantic signals, and some of our panelists need to go to the other side of the promenade.
Yeah.
This has been a great conversation. I want you to please help me thank the panelists for this insight. A conversation to be continued.
Yes.
Maybe 2 or 3 quick takeaways. Investment opportunities abound throughout the continuum. AI is making a difference, and it will make a bigger difference. We need to continue to focus on talent and capability and partnerships. That's where the conversation continues.
Thank you very much, sir.
Thank you all.